I just wanted to note before I start that today marks the start of National Reconciliation Week, and so I'd like to acknowledge that we're meeting here on Gadigal land. And I'd also like to acknowledge the Larrakia people, who are the traditional owners of the land on which I live and work these days up in Darwin. And I'd especially like to acknowledge the First Nations people of Papua, who are important stakeholders in the work that I'm going to be presenting today. Also just wanted to acknowledge that I'm presenting this on behalf of a team of people who are here on the slide. And I'd especially like to acknowledge Dr. Trazasi Lastari and Dr. Rini Posporojo, who have been working tirelessly to improve TB control in Papua for many years and have put a lot of work into this area. So Papua is located in eastern Indonesia, as you can see there on the map. And our work is based in our research site in Timika, which is that sort of whiter point on Indonesia. And you can see, I just put this in just to show, give you some perspective of how close Indonesia is to us, and in particular Papua province. It's really just a mere hop across the Arafura Sea, much closer than it is to come down here to Sydney. And so just some background on Papua province. So it's an incredibly culturally and ethnically, geographically diverse area. You can see there the map at the top, so that's Papua province. It shares a land border with Papua New Guinea to the east. And that little sort of white highlighted area is Mimika Regency. So I'll be showing a bit of data later in the presentation, and that's the area that we're working in, and the data is for that region. It's an incredibly resource-rich part of Indonesia, but unfortunately that doesn't reflect in the sort of development and living standards of people who live in Papua province. You can see it's very sort of undeveloped, incredible place to fly over the top of, very sparsely populated interior, very mountainous, difficult, challenging terrain. And that in itself poses a lot of challenges to implementing TB contact tracing and care. As I said, it's very ethnically diverse. There's over 300 Papuan tribes living across Papua province. And in terms of the TB situation there, it's an incredibly high burden setting for TB. So in Mimika, Regency has a relatively small population that's focused in a mix of urban sort of township in Timika and then rural villages. And the TB notification rate in Mimika is about 800 cases per 100,000. So that's just notification rate, not incidents. And that's versus only 200 odd nationally across Indonesia. You can see there over sort of the last few years, there's been improvements in case finding in Papua up until COVID happened, and the graph in the bottom right, you can see presumptive case numbers have really dropped off since COVID happened. It's also a setting that has a high burden of drug-resistant TB as well. I'm going to focus on TB screening and contact investigation. So contact investigation in Papua was first implemented in 2017, and it's been sort of gradually scaled up since that time. And its focus has been on household contacts of TB cases. There's been more recent efforts to expand that to including not just contacts under 5 years, but screening and preventive therapy for all ages among household contacts, and then other risk groups such as healthcare workers, prisoners, various office workers and others. And coverage for contact screening has been improving over the years, but overall it's still relatively low, and I'll show a bit of data later. Just to mention about preventive therapy, so primarily this is given to child contacts under 5 and people living with HIV, but there has been some recent policy changes, and so we're starting to see some expansion of the use of preventive therapy. So the new recommendation is for household contacts who are of all ages who are tuberculin skin test positive. although that's only at this stage been implemented in children and adolescents up to 15 years of age, and then other groups such as healthcare workers and prisoners. 6 months of isoniazid is the main regimen of being used for preventive therapy. However, the new recommendations have included 3-HP, although rifapentine is not yet available in Papua. Just to mention too, levofloxacin and ethambutol is being used for contacts of MDR TB, albeit in very small numbers at this stage. So here's just some data to show coverage of contact investigation, number of contacts investigated, and number of under 5 contacts who are started on preventive therapy. And you can see improvements over the last, well, up until COVID, over the last 4 years. Coverage of contact tracing has improved. The number of contacts identified per case, so that's the middle graph there, has remained fairly stable. And uptake of preventive therapy has increased as well up until last year when COVID happened, and you can see substantial declines in all of those. Just to note as well, in terms of the uptake of preventive therapy in under 5 contacts, so in 2019, that was at 70% of eligible contacts started on IPT, much higher than the national rate, which was only around sort of 9% of contacts. So Timika was doing quite well in giving preventive therapy. Just wanted to go through some of the challenges, and I've divided these into sort of general, long-standing challenges and some that are more specifically related to COVID. So one of the big general challenges we face is that contact tracing is done by teams of contact tracers who are based in the public health centres. However, about 50% of TB cases are diagnosed and managed through hospitals, and the hospitals don't have capacity to do outreach for contact tracing. So that means a substantial block, almost 50% of cases are not really getting access to contact investigation. However, that is starting to change. Uptake and adherence with preventive therapy is certainly suboptimal. And there's probably many complex reasons for that, some of which we're sort of trying to investigate further. But certainly one of the big challenges in Papua comes back to that sort of cultural and language diversity. So there's many local tribal languages which are spoken. And so communication is a really a big issue for the healthcare workforce over there. There's also financial barriers and logistic travel barriers that people face in accessing health services and preventive therapy as well. And another big challenge as well is, I mentioned earlier, the terrain is very difficult, and so contact investigation can be a very expensive operation. Some villages are only accessible by boat or helicopter or 2-day hike through the jungle to get to do contact investigation and give preventive therapy. And then related to COVID specifically, so like has been seen in many contexts, staff have been diverted away from routine TB services to respond to COVID. Clinical services have been limited, cut back. And one of the big issues we've been finding is that there's a lot of fear and stigma within the community around COVID, and that's really had a bigger impact on TB services. So patients have been very reluctant to present to health services for TB care. So in our treatment of TB cases, we've seen an increase in people sort of lost to follow-up and dropping out from TB care. There's also been a lot of wariness and fear of stigma from contact tracing teams visiting households. People are worried that their neighbours might perceive that they've got COVID in the household if contact tracers are visiting them. And there's also been a reluctance of people in the community to report their symptoms, especially cough and fever, for fear of it being sort of mistaken as, or them being diagnosed with COVID. So just a bit in terms of sort of what we've been doing to try and support contact investigation and preventive therapy. So we've had a range of activities. A lot of it's focused around providing training and education opportunities to healthcare workers on the ground. That figure down in the photo down in the bottom left of the screen is a recent workshop that our colleagues in Indonesia held for laboratory staff to give some training and updates on GeneXpert and solve other laboratory issues in Papua. And there's been a range of other sort of both formal and informal education and training that's being provided. Regular or quarterly continuous quality improvement workshops are being held. We've had a social media discussion forum and things like WhatsApp chat groups to allow healthcare workers to share information and answer difficult clinical questions and things like that. And also promotional materials, so things like short videos, such as interviews with Papuan healthcare workers, which are done in local Papuan languages, and those can be easily shared via WhatsApp and used as sort of education or advocacy tools. Just to mention too, so there's a series of new guidelines in Indonesia for latent TB, TB and drug-resistant TB. And these pose both opportunities and challenges. So the good news is that the new guidelines are more closely aligned to sort of best practice international guidelines, which is a good thing, but they also introduce changes in practice. So for latent TB, with increasing the use of preventive therapy in older age groups based on tuberculin skin testing, implementing tuberculin skin testing is a challenge. As I mentioned, they've been holding quarterly continuous quality improvement meetings where the staff get together, review data, both on treatment of TB as well as on contact investigation and preventive therapy, and sort of take a data-driven approach to sort of looking at the issues, the performance of the program, and identifying solutions to those barriers. Those meetings have been interrupted a lot with COVID over the last year or so. And they shifted to Zoom for the most part, but are now sort of coming back to a blended model of face-to-face meetings and online meetings as well. Next is just a couple of photos. So this is our colleague Krista, who is in the field in Timika recently, interviewing a parent of a child on preventive therapy and staff in the health centres to try and identify financial costs associated with preventive therapy, both for patients and for the healthcare system, and other sort of barriers and logistical issues. So just in conclusion, Papua is a complex and challenging place to work. Like elsewhere, COVID has had a huge impact, and it really highlights the need for TB programs, both here in Papua, but elsewhere, to look at how they can safeguard themselves against external threats. So now it's COVID, but there's always a risk of other things. In Papua, there's natural disasters, there's a risk, potentially of insecurity and conflict and other things that can interfere or interrupt routine TB program work. In terms of the key priorities, we've got obviously the need to ensure that TB cases managed through the hospitals still have access to contact investigation. There's a need to continue to work towards expanding TB screening and preventive therapy beyond child contacts of TB. There's a real need for better and simpler systems for recording and reporting data. So one of the issues is there's currently a hybrid of paper and electronic systems, which are very complex to navigate and difficult to extract data from. So there's a need for improvements there. There's a need to develop resources, tools and capacity for delivering care that's in a patient-centred and culturally safe and appropriate way. And it was good that this was a topic that came up in our discussion group and mentioned, I think, in Angela's presentation earlier, the issues around delivering care in that patient-centred and very culturally appropriate way. And also there's a need with the new guidelines that are out, there's a need for resourcing to be able to implement those new guidelines. So that's it.